also for the kind invitation by the scientific committee. So on behalf of my colleagues, I'm delighted to present our experience with ALL, obviously with some background on this particular disease. So as a way of objective, first I'll outline the therapeutic landscape in the treatment of ALL, particularly with the advancement that we have seen in this field over the last few years. And then I will highlight our experience at National Guard in Riyadh, and then I'll conclude with some future directions. So as you can see, this is a nice slide from a publication from the New England Journal about 2 or 3 years ago. It illustrates essentially how the outcome of ALL has changed, particularly in pediatrics. So a patient who was diagnosed in the 60s or 70s, we can expect to cure about 10 to 20% of them. And obviously over the last decades, we have made substantial improvements, and now a patient who's diagnosed in the current era can expect to have a 90 to 95% overall survival. Now, unfortunately, or fortunately, if you see the opportunity for improvement, we haven't made the same degree of improvement or progress for adult ALL. So a patient who's diagnosed with adult ALL currently can probably expect a survival of somewhere between 50 to 60%. Can you hear me now? Okay, great, thank you. So a patient who is currently diagnosed, an adult patient in the current era, can probably expect a survival of somewhere between 50 to 60%. Now obviously we haven't made the same level of improvement compared to our colleagues in pediatrics, and one possible conclusion is that maybe adult hematologists are not as good as their pediatric colleagues, but I think there's probably a little bit more to that. And one part of the story is that the disease in and of itself is different. We do observe higher risk cytogenetics in adult ALL compared to pediatric ALL. So for one example, about a quarter of patients have Philadelphia positive ALL, and probably around another 20 to 25% have this newly described entity of pH positive ALL. Now, there are additional factors as well, such as the compliance to therapy, which tends to be substantially better in pediatrics compared to adult. The same thing as the tolerance of the intensive regimen, particularly those regimens that include asparaginase. So I think a number of reasons can be the cause of this inferior outcome in adult, and I'll highlight some of the progress that we have made in ALL therapy over the last 2 decades. So TKI therapy for pH positive disease, imatinib and the newer generation drugs have substantially improved the outcome of ALL therapy compared to historical patients that have received chemotherapy alone. Addition of rituximab in CD20 positive disease, CD20 positive expression in and of itself is a negative prognostic marker, and a number of groups recently published randomized trials that have shown that incorporation of rituximab improves the outcome of these patients, both Burkitt disease and the less mature pre-B ALL. Pediatric protocols, the first publication from this was by Professor Stock from Chicago around 2008, that clearly showed that using a pediatric approach, or what they call a pediatric inspired protocol for patients that are adolescent or young adults or the AYA population, improves their outcome. Stratification of response guided by either minimal or measurable residual disease, particularly in pediatrics. And then recently, in the last couple of years, the incorporation of novel antibody constructs within our treatment algorithm. And we're still learning how to use these. So both the blinatumomab, which essentially links your CD3 positive T cells with the CD19 positive tumor cells, or inotuzumab, which essentially incorporates the cytotoxic drug calicheamycin with CD22 positive antibody. And then more recently, as you heard this morning, in the context of myeloma and lymphoma, the CAR T cells in the relapse or refractory setting. And we're still learning how to incorporate these drugs, and there's still a lot of work to be done in terms of their incorporation. So obviously the first few points were with regards to the treatment itself. We have also made some improvements with supportive care, and I think collectively that's where we have seen the majority of the improvement. But as you've seen before, there's still room to be done, particularly with regards to adult disease. Now, this slide highlights the outcome seen with the traditional hyper-CVAD protocol. So essentially this was one of the earlier publications by Professor Kantarjian, where he compared your hyper-CVAD protocol to a VAD backbone. And you see with a traditional hyper-CVAD, you're expected to see, without transplant, you're expected to see probably a long-term outcome of about 30-35% or so. Now, recently, the group at MD Anderson have updated their protocol, so they've modified it with a few things. So they've incorporated the CD20 positive rituximab, they've augmented the dose of the anthracycline, and they've also added an intensification phase, so early and delayed intensification built in within the maintenance phase. And you see you can improve the outcome of these patients. You can lift up this 30%, probably somewhere to 50 or 60%. Now, so what do we do with regards to transplant? I am a transplanter by training, and then the question of transplant in ALL is always strongly debated. Do we transplant this person? Do we not? I think the best literature that we have is probably outdated with the current stratification system that we have, but this particular slide highlights the first study that was reported in a randomized fashion by the French group, the LALA study, where they've essentially randomized patients based on donor, no donor, what they call genetic randomization. And they saw that transplant essentially improved the outcome of patients, but restricted the benefit that was observed in patients that had high-risk disease. Now, fast forward a few years, but still 2008, the collaborative MRC and ECOG trial essentially did a similar design with a much larger group of patients, but what they observed essentially that the benefit of transplant was restricted to patients that had standard risk disease. So conflicting conclusions. The ASBMT and EBMT a couple of years ago published their recommendations in terms of who would benefit from transplant in first remission, adult patients, and there were some differences between the guidelines, but generally the idea was to reserve transplant in first remission in patients that have high-risk disease. But with one caveat is that the definition of risk stratification in ALL, as you know, is a moving target. So how we defined high risk or standard risk a few years ago is probably not the same as how we would do it today. So one thing about the pediatric protocols, one of the earlier publications, if not the earlier publication, was by Professor Stock, and she retrospectively examined the use of a pediatric inspired, in fact, this was a pediatric protocol, patients that were treated on the CCG group, but younger patients, so the AYA population, compared to patients that got the historical CLGB protocol. And what they noticed is that the outcome was significantly better. So obviously this sparked a lot of interest. A number of groups have published their own experiences retrospectively, which confirmed these findings. The most important one, I think, was by the Dana-Farber group, published by Dana-Farber group, as well as other centers that have adopted their protocol. And actually, this led to the prospective C10403 trial that was hopefully will be published soon. This slide was provided courtesy of Dr. Stock. And you essentially see that the outcome of these patients has improved still compared to historical controls, although with the one caveat, even though actually I thought the slides were behind me. So even though the outcome is reported as 60% at 3 years, you see the curve actually doesn't plateau yet at that time point. It still drops beyond the 3-year mark. So it's, in spite of using, I think the conclusion of this is that in spite of using a pediatric protocol, the outcome using these patients in adult ALL, even the AYA population, is still not the same as pediatric patients. So I don't think the AYA protocol is going to be the answer to all of our concerns. Okay. Now, with the same study, they have actually examined patients that have had MRD tested at the end of induction. About a quarter of the patients or so had their MRD tested. And again, as we saw with previous studies, and as confirmed by a number of other groups, essentially having measurable or minimal residual disease at the end of induction is a poor prognostic marker for outcome. But then how do we approach this is still a matter of debate in the adult literature. The management is much more defined in pediatrics, but we're still learning what to do with this in adults. The MD Anderson actually challenged the notion that the AYA protocol is better than their modified hyper-CVAD, and they've actually done this, their own retrospective study about a couple of years ago, and there were 2 publications that came out of this. And what they have noted, or what they've reported essentially, is that patients that were treated with their modified hyper-CVAD do comparably to patients that receive their BFM protocol. And I think there was probably an element of some selection there, but the one thing that's clear is that the pattern of toxicity that you see with BFM versus hyper-CVAD is different. With hyper-CVAD, as you know, we get a lot of cytopenia-related toxicity, bleeding, infection, and the like, whereas with BFM, you get some asparaginase and liver-related toxicity. Now, what about our center at National Guard in Riyadh? Over the time period from 2010 until 2017, we have actually treated patients in the following way. So patients that were defined as high risk with the following definition, and some may argue whether this may necessarily be the consistent definition of high risk, but we have transplanted those patients in first remission if they were young, fit, they had a healthy donor, or available donor, excuse me. And patients that had standard risk, we have treated them with the modified hyper-CVAD. So we have transplanted patients in first remission, a total of 47 during this time frame. And we have treated with modified hyper-CVAD a total of 38 patients. Now, patients that were beyond first remission, they were treated with transplant if feasible, and there were a total of 27. And we had other patients, obviously, that were refractory and not salvageable, or frail, elderly with comorbidities, that we were treating them with palliative type approach. So when we did the comparison between hyper-CVAD and continued and versus hyper-CVAD followed by transplant in first remission, and typically most of the patients got around 2 cycles of hyper-CVAD. Some got a little bit less and some got a little bit more, depending on when the donor was available and when the patient was ready. But generally speaking, the baseline characteristics of these patients were similar, as you see, obviously with the exception of the risk factors. So patients that were transplanted were more likely to have either higher risk cytogenetics, higher presenting white cell count, etc. However, you would note that some patients did have some high risk features, but treated with hyper-CVAD alone, either because we felt that the patient was either not fit for transplant, or the patient did not have an available donor, or the patient declined in 1 or 2 instances. So we had to adjust, obviously, in terms of the outcome. We had to adjust for these high-risk features when we did our multivariate analysis for EFS and for overall survival. And what you see is that for EFS, we did have induction failure, meaning that you had more than 5% blast post-induction as a negative prognostic marker, whereas transplant in first remission, there was a trend towards a favored outcome, although this didn't quite meet statistical significance, obviously with a caveat of the sample size that we have. Overall survival, we observed that transplant was the only favorable marker that we observed in our patient population with a hazard ratio of around 0.3. We would love to confirm these findings, obviously, with colleagues in the region to see how we can move forward with this. Now, we also, this is not, okay. So we also examined our post-transplant outcome in general in ALL, regardless of the remission status. And then this is essentially the baseline characteristics of the patients. You would note that they were generally younger patients. Most of them had B-cell disease. Most of them had lymphoblastic leukemia. Most of them were transplanted from a sibling donor. And then the majority, because of their age, they were fit. They received myeloablative conditioning with a TBI backbone. Survival based by remission status is not a surprise to see that patients that were transplanted in first remission obviously do better. We have to wait a little bit longer because some of these patients were just transplanted in 2017, so we have to see with longer follow-up if these outcomes hold. I predict that we probably will see some subsequent events, but time will tell. We also looked by incidence of chronic graft-versus-host disease, regardless of severity. So whether it was mild, moderate, or severe, patients that had some element of chronic GVHD, they do better, presumably because of this graft-versus-leukemia effect. So in terms of future directions of where we can move forward, so globally there is actually a US intergroup study that just opened a couple of months ago. This essentially is a next step building up on the prospective AYA protocol that I shared with you earlier. So that the design is the same, but with 2 important differences. So number 1, all patients that have CD20 positive disease will get rituximab in the induction. And then the next change is that once patients achieve remission post-induction, they'll be randomized to 2 cycles of inotuzumab, compared to continuation with the consolidation and maintenance phase. And essentially the point, or the primary endpoint of the study will be 3-year event-free survival. So it will still take us a little bit of time before, probably it will be at least 3 to 4 years before we can get some results on the study, but it will obviously be very interesting to see if whether incorporating the novel agents or the novel antibodies up front in the therapy is going to change and lift up this curve that we have in the adult ALL population. Now, another proposal by the MD Anderson group, I'm not really sure where this is in terms of its conception, if it's still in conception or they're actually enrolling patients, is essentially incorporating both antibodies within a mini hyper-CVAD backbone. And the idea from this was based on their successful experience with mini hyper-CVAD with single agent blinatumomab or inotuzumab, which was recently reported within the last year or 2. So they their intention is whether combining both antibodies is going to augment the survival curve. And essentially the design from this, just to take you for a few seconds, is to give a mini hyper-CVAD in conjunction with inotuzumab for the first 2 cycles, and then for 5B and 6B, give 2 months of blinatumomab, and then what they called a consolidative phase, so the remaining 2 cycles of hyper-CVAD, so 3A, 3B, 4A, 4B, and then finally give 2 more cycles of blinatumomab, and then go on to a maintenance phase of 12 months. One thing to note is that the dose of inotuzumab was reduced given concerns of toxicity, particularly with regards to the liver. So we'll see, it'll probably take a few years to see where this translates to. And another step forward, I guess, what a future regimen might look like is to incorporate what I just described and then give CAR T cells in a state of minimal residual disease, or if a patient has any residual disease, in a consolidative phase, what they call consolidative phase 2. So obviously it's going to take some time before there's a lot of effort and a lot of work that has to be done in this kind of patient population. But again, from a perspective of a glass half full point of view, hopefully the future is going to look a lot brighter for these patients. So for future directions at our center, we have actually at the beginning of 2018 started to incorporate an AYA protocol based on the BFM in conjunction with and collaboration with our colleagues at National Guard in Jeddah. And this has been led locally in Riyadh by Dr. Hind Salama. And we're obviously hoping to incorporate and to merge our data with other centers to see collectively how we're doing and where we can move forward. Another point essentially is to incorporate antibodies in a chemo backbone. So currently what we do is to give blinatumomab in patients that have MRD positive disease based on the recently approved indication, and also to use these antibodies in the relapse or refractory setting. So either as a single agent or in a chemo backbone. We have done that in a context of mini hyper-CVAD in a couple of patients. We've also treated 1 patient with daratumumab and mini hyper-CVAD with T-cell disease. I think a lot of what we talked about today is B-cell driven, but I think there's a lot of work that remains to be done in T-cell disease. And one of them is incorporation of daratumumab, hopefully will result in some meaningful improvement. We also would like to identify the BCR-ABL-like, although it was still not clear to us at this point what are we going to do with this information in terms of treatment. It's not clear whether adding TKI therapy, whether adding ruxolitinib, or whether transplanting them in first remission is going to improve the outcome, but at the very least, identifying them is going to be one step forward towards treatment. And lastly, incorporation of CAR T cells. We're still trying to figure out how to do all of these things in a cost-effective manner, essentially, where we can minimize the benefit for the patient, but maximize the benefit of the patient, but with the minimal, as much possible in terms of expenses. And I think that's all I have for today, and I would really like to thank all of my colleagues at National Guard in Riyadh, where essentially we're able to show you the results that we have today. And with that, I would like to thank all of you for your attention.